Hi, I'm Tara Niemeyer, and a health policy I feel passionate about is the Children's Health Insurance Program, otherwise known as CHIP. It was established in 1997 under Title 21 of the Social Security Act to provide health coverage to uninsured children in families with incomes too high for Medicaid but too low to afford private insurance. This is a joint federal-state program which gives states flexibility in design and implementation. States can run the program as a Medicaid expansion, a separate CHIP program, or a combination of both. CHIP covers routine checkups, immunizations, doctor visits, prescriptions, dental and vision care, inpatient and outpatient hospital care, and emergency services. CHIP is important because it provides health insurance to children. It reduces the uninsurance rate among children. Before this policy in 1997, the uninsurance rate in children was 14.9%. In 2022, it was 5.4%. It also improved access to preventative care such as dental, primary, and specialty cares. It provides financial protection for families, and it supports children with special health care needs that are often excluded from private plans. It protects vulnerable families, serving as a safety net, especially during economic downturns. CHIP has a positive impact on health and wellness of different populations. It impacts low-income families, racial and ethnic minorities. Medicaid and CHIP together cover about half of all children in the U.S., many who are minorities. It also impacts the health of children with special health needs by covering speech, physical, and occupational therapies. Primary data directly from individuals or communities for research and surveillance purposes is crucial for identifying real-time health needs and disparities. One primary data source is the National Survey of Children's Health, otherwise known as NSCH. They collect parent data on children's physical and mental health, insurance status, access to care, and social determinants. This data is used to track trends in children's health and coverage. For example, in a 2023 NSCH survey of North Dakota on consistent healthcare or health insurance coverage, 92.8% of children had consistent health insurance coverage for a full year, and 7.2% of children did not. Secondary data are often originally collected for different purposes, but are repurposed for an epidemiological analysis. Examples of secondary data include hospital discharge data and claims databases. This data can be evaluated to track patterns of emergency department visits and chronic disease management among insured versus uninsured children. For example, CHIP-covered children have more emergency department visits and less routine dental exams and cleanings than children with private insurance. Like any policy and program, the CHIP program comes with some challenges. First, it is not permanently funded and requires reauthorization, leaving uncertainty for states and individuals on the program. Second, state-by-state variability leads to differences in coverage, in benefits, and eligibility, resulting in inequality. Lastly, there is a large amount of children who are eligible that remain unenrolled due to the lack of awareness and administrative barriers. American Academy of Pediatrics recommends federal uniform eligibility and benefit standards to reduce disparities. They also recommend extending continuous eligibility. Research shows 12-month continuous coverage improves health outcomes. Therefore, the American Academy of Pediatrics, or AAP, recommends continuous coverage without renewal from birth to 6 years, then renewal every 2 years from 6 to 26 years. Another recommendation is to promote school-based programs and community health workers to identify eligible children and assist with their enrollment. New York improved their CHIP program by adding school-based CHIP outreach. Their goal of school-based outreach was to increase CHIP enrollment. New York Public Schools partnered with local health departments to provide on-site enrollment for children at parent-teacher conferences and school registration. They also offered material in multiple languages to assist with language barriers among immigrant families. A marginalized population that is currently left out of the CHIP program in most states is undocumented children. Families that have fluctuating income are also affected as they cycle in and out of eligibility, affecting their continuity of care. Rural residents who qualify often have provider shortages and may have transportation barriers that limit access to care. Finally, coverage currently ends when a patient turns 19, leading to abrupt loss in coverage. In conclusion, CHIP is a great program that provides health insurance to a marginalized population that fell through the cracks. Although it promotes health and access to care, the policy can be improved by eliminating barriers to enrollment, eliminating state to state variability in coverage, and reducing renewal requirements to ensure continuity of care and coverage. Thank you for listening to my presentation.